Quadriceps muscle group.
Right in here.
Sartorius muscle.
And it comes off here and goes all the way down here.
Quadriceps tendon.
It's above the patella right here.
Patella.
Right here.
Patellar tendon.
Comes down and touches tibial tuberosity.
Tibial tuberosity.
That is right in here.
Lateral meniscus and joint line.
You come up. Right in here.
Fibular head.
That's down right in here.
Lateral collateral ligament.
That runs from the fibular head to the lateral femoral condyle.
Popliteus tendon.
That goes posterior to the LCL.
Biceps femoris tendon.
That's right in through here.
IT band.
That goes from Gertie's tubercle all the way up through here on the lateral side.
Gertie's tubercle.
It's right here.
Medial meniscus and joint line.
It's right in here.
Medial femoral condyle.
That is right here.
Medial tibial plateau.
That is located inferiorly right in here.
Medial tibial flare.
That is located inferior to that right in here.
Medial collateral ligament.
That runs from up here and attaches below the medial tibial flare.
Pes anserine tendon and bursa.
That's located lateral in here, and then the bursa is just underneath the skin but above the tendon.
Semitendinosus tendon.
It's on the medial side. It's right in here.
The gracilis muscle.
It goes from the pes anserine, it wraps up through here and goes up to the groin.
Hamstring muscle group.
It's on the back, posterior side.
Poplita fossa.
It's like the diamond shape. It's hard to see, but it's right in through here in between the two tendons.
Head of gastric muscle, Nemeus muscle.
Comes right up through here and touches the condyles. Okay, now I'm going to do active range of motion for knee flexion. So I'm going to have my patient move their foot all the way up to their butt and then all the way down for extension. Now I'm going to do goniometer. So the fulcrum will be at the joint line. Will be here. And now I will have my patient extend their knee. That is about -5, which that's in between the normal range of 0 to -10. So now I will have them flex their knee. And that is about 135, which the normal range of that is 135 to 145. So now I will do passive range of motion. So I will flex my patient's knee and extend it. When I flex it, there should be a soft end feel. When I extend it, there's a firm end feel. Now I'm going to do manual muscle testing. So I'm going to have my patient tied to the end of the table. For knee extension, I'm going to have you push up. Okay, that was good. That was a 5 out of 5. And now I will have you on your stomach prone for flexion. So I'm going to have you about 45 degrees. So I'm going to have you try and push up. That would be 5 out of 5. Now I'm going to have you point your toes towards your other foot for internal rotation. Now I'm going to do the same thing, 45, push up. That would be 5 out of 5. Now I'm going to have you externally rotate, so push your toes this way. Okay, now I'm going to have you press up. That would be good. That would be 5 out of 5. And all of these tests I would compare bilaterally. Okay, now I'm going to go on to my manual muscle test, or my special test. So first one I'm going to do is a sweep test. So I'm going to compress together, and if there is edema on the medial side, that would be positive. That would be fluid within the joint capsule. The next one I'm going to do is the balbitable patella test. So I'm going to hold above the patella. I'm going to push down into the femur, and if there is a floating patella, or the patella moves downwards and then comes back, it would be positive for joint effusion. The next one I'm going to do is no-bows compression. So I will have it over the IT band, and I'm going to flex and extend, and if there is pain over the lateral femoral condyle, that could indicate IT band friction syndrome. The next one I'm going to do is Godfrey's 90-90. So I'm going to have you up here. There should be a straight line. If there is not and the tibial tuberosity drops, that could indicate damage to the PCL, which would most likely be a sprain. Next one I'm going to do is valgus stress test with full extension. So I'm going to be applying a valgus force, and if there is problems with that, it could indicate MCL, medial capsule, or damage to the cruciate ligaments. Then I'm going to do 20 degrees of flexion. I'm going to do the same thing. I'm going to apply a valgus force, and that is just testing the MCL. Now I'm going to do various stress tests. I'm going to have full extension. I'm going to be applying a medial force. That is testing the LCL lateral capsule or the cruciate ligaments. I'm going to have 20 degrees of flexion and apply a valgus or a varus force, and that would indicate damage to the LCL, which all of these would be bilateral. Now I'm going to do the lateral pivot shift maneuver. So I'm going to abduct, internally rotate the tibia, apply a varus force, all while flexing and extending the knee. If there is problems with that, that could indicate anterior lateral rotary instability. Next, I'm going to do anterior drawer. So I'm going to sit on your foot, and I'm going to be within the plateaus, and I'm going to pull anteriorly. So if there's problems with that, if the tibia moves forward anteriorly or there's a lot of laxity, it can indicate ACL damage. Now I'm going to do slocum interior drawer. So I'm going to internally rotate the foot. I'm going to do the same thing. I'm going to push up, and if there is laxity or the tibia comes forward a lot, that could indicate damage to the ACL, the LCL, or the lateral capsule. I'm going to do slocum drawer external rotation. So I'm going to pull up. That could indicate damage to the ACL, MCL, or medial capsule if there's a lot of laxity within the tibia. Now I'm going to do Lockman's. So I'm going to have you straighten your leg. I'm going to be right here. I'm going to put pressure on the fibula, and I'm going to bring up the tibia. So I'm going to bring it anteriorly. If there is laxity or pain with that, that could indicate sprain or tear of the ACL. Now I'm going to do posterior drawer. So I'm going to be pushing back, and if there is a lot of tibial shifting posteriorly, that could indicate damage to the PCL, a sprain or tear. Now I'm going to do Hutcherson's posterior medial test. So I'm going to have you internally rotate your foot. I'm going to sit on it as best as I can. I'm going to push backwards. That could indicate damage to the PCL, the MCL, or the medial capsule. Now I'm going to do Hutcherson's posterior lateral test. So I'm going to be pushing backwards. If there is increased glide with that, or the tibia moves posterior a lot, that can indicate damage to the PCL, the LCL, or the lateral capsule. Now I'm going to do Felseli's test. So I'm going to have the patient stand up. I'm going to have them stand on the affected leg, so one leg is bent, one leg is straight, and they're going to be in about 5 degrees of flexion of the knee. So it's barely flexed, and then they're going to internally and externally rotate their femur 3 times. If there's pain with that, that could indicate meniscal tear. And we're also going to do the same thing at about 20 degrees. internally rotate, externally rotate. If there's pain or also popping or clicking, that could indicate meniscus tear. So now I'm going to do McMurray's. So I'm going to have my hand along the joint line. I'm going to internally rotate the foot while coming and flexing the knee and extending it. And then do the same thing with external rotation of the tibia. We're going to go flexion and extension. If there's pain or popping or clicking on either the lateral or medial side, that can indicate a meniscal tear on whichever side is affected. Now I'm going to do Apley's compression and distraction test. So with Apley's compression, I'm going to be compressing downwards on the tibia, and I'm going to internally rotate and externally rotate the tibia. And if there's pain with that, then we're going to try the distraction. So I'm going to be pulling the tibia up away from the femur while internally and externally rotating. And so if there's pain with the compression and relief with the distraction, that could also indicate a meniscal tear. So now I'll do the special test. So now I'm going to do my dermatomes. So for S1, it comes from the iliac crest and goes to the groin, so it's up high. So I'm going to have my patient close my eyes and ask them if it's sharp or dull, and see if they can feel that. Now, L2 is slightly lower, comes from the ASIS and goes down to the groin. So I'm going to ask them sharp, dull, sharp, dull. Next one I'm going to do is L3, which is the anterior medial side of the leg. So I'm going to ask them sharp or dull with their eyes closed and see if they can tell the difference. Then L4 is by the patella. So sharp, dull, see if they can tell the difference. L5 is the lateral side of the lower leg. So sharp, dull, sharp, dull. Then S1 is the lateral hamstrings. So I will have them ask if it's sharp, dull, and then S2 is the medial hamstring, sharp, dull. So now myotomes for L1 and L2, it's hip flexion. So I'm gonna have my patient bring their leg up towards them for hip flexion for L1 and then hip flexion for L2. For L3 is knee extension, so I'm gonna have them come off the end of the table and extend their knee all the way up. L4 is ankle dorsiflexion, so I'm gonna have them bring their leg up towards them. And L5 is great toe extension, so they'll bring their big toe up towards them. S1 is ankle plantar flexion, so they'll press like they're on a gas pedal. And S2 is knee flexion, so they're gonna bring up their knee up towards their chest. And the last thing is the reflex testing. So those are all myotomes. Now we're on to reflex testing. L1 does not have a reflex. L2 through 5 is the patella tendon. So I'm gonna see if it fires. There we go. So L2, L3, L4, and L5. And then the reflex testing for S1 and S2 is the Achilles tendon. So it's going to be back here. So S1 and S2.